Afternoon, everyone. My name is Rieta Aben. I am an internal medicine resident in Macon, Georgia. I am also a research fellow at GAC Research Institute under the leadership of Dr. Sagadi. My case this afternoon is atrial fibrillation and heart failure in the setting of Graves' disease. I'm going to walk you through a little bit of what happened to our patient and kind of review the current guidelines as we go through it. I have no disclosures, and I'm going to try to go through the case relatively quickly. So this is a 53-year-old African male who presented with worsening palpitations, dyspnea, cough for the past several days. He essentially had no cardiac or medical history that he was aware of. In regards to his medication, he wasn't taking any, not even anything over the counter as well. The only thing he did admit was that he quit smoking about 4 years ago. On presentation, his vital signs, he was hypertensive. Blood pressure was 155/86. Heart rate was 168. He was normal temperature and saturating appropriately 98% on room air. On the review of system, the only thing he did admit was dyspnea on exertion, leg swelling, 20-pound weight loss, which he attributed to him eating a lot healthier, as well as some blurry vision. On physical exam, as you can see some key findings here, signs and symptoms pointing towards heart failure. He was just in moderate discomfort because he was having a little bit of a hard time taking some deep breaths. Of note, there was a left thyroid nodule that was felt on physical exam. This was his initial EKG in the emergency department, and as you can see, it was showing a rate of approximately about in the 100, 140s or so. On his labs, essentially his CBC, his chemistry was relatively normal. His hemoglobin was 11.2. His kidney function was also intact. He had mild liver function elevations, which he ended up telling us a little bit later on that he might have had hepatitis B at some point. His A1C was 5.0. Lipid was essentially unremarkable. On the cardiac standpoint, his troponins was normal. He had an elevated BNP. His chest x-ray was consistent with pulmonary congestion. And his TTE that was obtained showed an EF of 40 to 45% with biatrial enlargement with mild global hypokinesis of the left ventricle and an RVSP, a right ventricle systolic pressure of 45 to 50 that was seen, and some mild valvular heart disease. His TSH, so his thyroid hormones, were quite significantly elevated, as you can see. He was borderline on a thyroid toxicosis approaching a storm. As you can see, the TPO thyroid peroxidase antibodies were also quite high, as well as his TSH receptor antibodies suggesting Graves' disease. And I forgot to just mention his thyroid ultrasound eventually was, there was really no nodules that was appreciated, just some diffuse enlargement. So he was diagnosed with atrial fibrillation as well as heart failure. He was started on Lasix, furosemide, 40 milligrams, which improved his symptoms. He was started on diltiazem, a 10 milligram one-time dose, and then continued on an infusion. He was also started on heparin, given the prothrombotic rate of thyroid disease. And he was also started on methimazole for his antithyroid drugs, as well as propranolol to decrease the conversion of the T4 to T3. Follow-up, of course, he followed up relatively shortly, and then eventually he was lost to follow-up. His 2 weeks heart rate was still elevated. TSH has still not come down despite being on medication, as well as his 2 months follow-up. And this is pretty much the algorithm according to the ACC and the AHA, walking through to the management in patients with atrial fibrillation when they come in the inpatient setting. So our discussion is a little bit going to be going through hyperthyroidism and what does the guideline actually say. So hyperthyroidism is a well-established precipitant of atrial fibrillation, and AFib occurs to 5 to 50% of hyperthyroid patients, depending on the study population and compared with 1 to 3% in the general population. And I have my references at the end of the slides. Current guidelines state that the management of AFib includes rate and rhythm control, as well as anticoagulation management. However, this is mainly for patients with a CHA2DS2-VASc score of 2 in male, 3 in female. In our patient, he had a CHA2DS2-VASc score of 0. So this is, again, the continuum in AFib, as we all know. Our patient was kind of falling possibly in a 3A or 3B. The key things that we could possibly think of in regards to his risk factors was possibly hypertension. However, he was never diagnosed with it. So the other factors included male sex, as well as his now diagnosed thyroid disease. So going through his CHA2DS2-VASc score, as you can see on the screen, his CHA2DS2-VASc score was essentially 0. He was a 53-year-old male, so his age fell under less than 65. No heart failure history until now. Hypertension, non-diagnosed prior until possibly now as well. And no history of diabetes as his A1C was 5.1. His thyrotoxicosis storm was 35, and above 40, that's when you start approaching a storm. So what does the guideline say in regards to the rhythm control? For heart failure with reduced ejection fraction, which our patient did not necessarily meet, he had mildly reduced EF, it definitely states that rhythm control, early rhythm control management will eventually improve symptoms, can reduce hospitalization, as well as decrease the likelihood of AFib progression. Now, the current guidelines, which is stated in the paragraph right underneath this table, says that restoration of sinus rhythm is unlikely until a euthyroid state. So I wanted to bring it to your attention that it takes about 4 to 6 months before patients, if they are compliant with their medication, to even get to that euthyroid state. And just a quick overview of all our AAD drugs, and the reason why he was not started on it is given the fact that he not necessarily met all the criteria, and the fact that also some of them could probably worsen his presentation. In regards to ablation, right now it definitely states that early ablation in patients with, and I'm reading from the second box in the guidelines, in selected patients younger with few comorbidities, which our patient probably met, that AFib in whom rhythm control is desired, catheter ablation is usually a first-line therapy. However, there's really no guidelines when it comes to hyperthyroidism. There was a paper that was recently published in 2021 by Dr. Krisai, and stated that catheter ablation for AFib in hyperthyroid states was associated with a high acute success rate. Although there are some studies that still need to be done, we still don't have a lot of data to support it yet. And going through a little bit in heart failure with reduced ejection fraction, there's significant data that says that it is beneficial to start rhythm control. But again, our patient was just at 40 to 45%, which kind of gave us a sense whether or not we ought to even start him on full GDMT at that time, or just control his symptoms, since it's a reversible cause that could probably be mitigated. However, our patient, after the 2-month follow-up, was no longer seen. I tried going through seeing if he was admitted at different hospital centers to see if we could still track him down. However, he was not found. So at 2 weeks, he was still on his anticoagulation, but after those 2 weeks, some of the notes that was on the medical record stated that he was no longer on an anticoagulation. So why do we even bother, right? So with our patients that sometimes are non-compliant or lost to follow-up, could early, of course, continuation of anticoagulation, the duration of it, how long should we possibly keep those patients on, given that the euthyroid state takes a while before it corrects? So hyperthyroidism is a known risk factor for atrial fibrillation with prothrombotic properties. And a CHA2DS2-VASc score may not be sufficient to assess the need for anticoagulation. Patient with low scores and high risk factor associated with thromboembolic risks, such as hyperthyroidism in our patient, should be taken into consideration. And addressing the cost of medication as well as access, and definitely the social determinants of health, making sure he's not in a medical desert as well, given that sometimes it's hard for them to come to the facilities. So a patient can relapse despite being treated with antithyroid drug therapy and can continue to have increased AFib burden and worsening heart function until TSH level normalize. There is limited data, and there is definitely consideration to explore this avenues a little bit further. And those are my references, and thank you.
I have a very nice case, Rita. It's a very clinical case in depth, and the question, you said there was a relapse after taking antithyroid medication.
So he was still, the levels were still elevated.
Okay, the next step from a medical point of view, do you go for radiation or radioisotope?
No, we usually
or surgery?
So we usually continue the medication to bring down the levels before considering a surgery or ablation at that time.
I mean surgery for the thyroid, yes. Yeah. And radioisotope, you mean radioisotope ablation of the thyroid?
They still need to be on those antithyroid drug medications.
So how long do they try the medication?
So they usually are on normally for at least 4 to 6 months. And then considering the surgical, and that's if they have, because the biggest thing is just for making sure that they don't progress into a storm. So you want to control first with the medications before going through a surgical avenue.
Do you try to cardiovert him pharmacologically?
We did not. He was started on diltiazem. His rate came down. Upon discharge, I believe his rate was in the 90s. But then he was still in AFib at that time.
How about beta blocker?
Yes, the beta blocker that he was on was just propranolol to aid the conversion of the T4 to T3 to help reduce that those thyroid hormones.
Do you expect him, if he keeps on antithyroid medication, to go back to sinus rhythm?
Normally, if they're kept on those medications, yes, they can revert back to sinus rhythm. However, there is still some data that's showing that some of these patients still revert back into a hyperthyroid state, and then there is still no clear evidence.
We have some experience with hypothyroidism and atrial fibrillation. Do you think there is a relation between hypothyroidism and atrial fibrillation?
Hypothyroidism.
No, hyper.
I'm not sure,
yes,
but
Felix?
I think...
I noticed this several times, and but I tell the patient, okay, this AFib is not from the thyroid.
No, it's one of the, when you look down, especially when they have severe hypothyroidism, and actually it's one of the findings in mixed edema crisis, atrial fibrillation can occur. And I've done a lot of AFib ablation. When I do AFib ablation in somebody relatively younger, and then I go back to look at their history, I see they have had a history of thyroiditis in the past. And it's kind of very unique when you do ablations in these patients. They have a lot of diffuse area, extrapulmonary vein triggers for atrial fibrillation. And they are younger, maybe 40s, 50s, and in whom you are not expecting to see that finding. I think perhaps we should probably look at that, maybe your experience, and we can go back in the States and look at, Because as Rieta is presenting now, I was thinking that some of these patients, even after they go back into euthyroid state, they still at a risk because I think the thyroid crisis creates some structural damage to the myocardium. It creates almost like an atrial myopathy by itself.
For those with hypothyroidism, is there a contraindication to use amiodarone? Hypo,
Yes.
not hypo.
For hyper,
Hypo.
yes. So amiodarone can definitely cause both hyper and hypothyroidism. Yes.
With hypothyroidism, we can use amiodarone. With hyperthyroidism, we can take the endocrinologist way he thinks about the thyroid disease. If the thyroid disease, the disease does not function at all, we can use amiodarone and take it off by surgery.
Actually, this is our experience. When I see hypothyroidism, I can use amiodarone safely, and it doesn't go to hyper at all.
Yeah, I mean, you know, for maybe Jody has some comment from the back.
Yes. We want to hear you.
Can you come around?
Come here.
Hyperthyroidism is an absolute contraindication to using amiodarone, but you can safely use it in hypothyroidism. Yes.
Thank you, Dr. Rita, for this brilliant presentation. And just one question.
Yeah.
I have one question before you.
He sold it
Dr. Mohammed Jamili is from Morocco.
Yeah.
I think the most important message of this presentation that we don't use Chad's Vasc in this patient with hyperthyroidism. And we should start anticoagulation at least on the moment of normalization of level of TSH on this patient. It's the most important clue of this presentation. Thank you, Mr. Rita, for this presentation.
Yes. Really, your presentation shows that patients are almost the same in those countries, because when sometimes we are in Africa, we think, in Cameroon precisely, we think that those patients really sometimes they're not compliant, they're not coming to the hospital despite the treatment. I want to ask this question. He didn't see, or people around didn't see his anterior chest neck, the anterior neck, to see that there's something, and sometimes in my consultation, people, when they are coming, they are not having any symptoms, but they say that I was told to come because my neck is like this, my neck, please, doctor, what is going on before the diagnosis is done? Yes. Secondly, about the treatment, I saw diltiazem at a particular time, and later on, propranolol. Were they giving to at the same time, or something was respected before? I don't know. And in your place, you cannot call phones. You are not calling patients for them to come back, I don't know, to sort out relatives, because in our setting, there are many phones, many contacts that we can really call if one is not available or one is not passing through.
So for the first question that you mentioned, I believe it was about the diltiazem, is that?
Yes.
The diltiazem. So diltiazem was started first, and then when the rate was a lot more controlled, he was transitioned to a PO, oral medication, and propranolol was started afterwards. In regards to the phones contacting our patients, one of the things that we struggle with sometimes is that patients get
They are cutting the electricity.
patients are lost to follow-up because some of them just don't want to pick up their phone because it requires money to come back in. And insurance is a big issue. So patients will say that, well, I'm doing relatively fine. I'm going to be okay. So sometimes it's a cost issue that you are calling the patient, they are seeing your calls, but they're just choosing not to come in because they sometimes know that it will require a copay or so on. Yeah, and now that he symptomatically feels better, now they just don't fall. And I think you had another third question.
The anterior face of the neck. Nobody told him that there was a problem there?
So when he first came in, the biggest thing that he kept on reporting to us was that there's swelling in my lower groin, in my right lower groin. He was more bothered by the hernia than what he was noticing on the neck. So he was aware. He's just, well, it's not hurting. It's swollen, but it's just not hurting. So, yeah. Thank you.
استعمل الميكروفون ده بهدي. استعمل
Thank you for all people stay at the late afternoon. We'll continue tomorrow, inshallah, at 8 o'clock. 8 o'clock, inshallah, 8 a.m. Thank you.